Yeah, good morning everybody. I'd like to thank Vijay Kumar Vada sir and Yashoda for giving me this opportunity. My topic is overview of staging systems. A lot of it has been already touched by the previous speakers. I will give a very brief overview, whatever I can in 6 minutes. So why staging is important? So when a patient walks into your OPD, why don't you just go up front and operate on the patient? Because what you see is a very small part. It's like the tip of the biological iceberg. There's a lot of it which is hidden underneath the surface. So staging is very important to realize which stage the patient is first. And how does this matter? So why do we stage before we slice? Because right from planning the strategy to the prognosis, everything is guided by your proper staging strategy. So it helps in treatment, planning treatment, it helps in guiding your prognosis, counseling the patient, and it also helps in classifying patients, taking them up for research activities and enrolling them in trials. TNM, again, I'll touch on it very briefly. You already know the stages, I hope, and based on the extent of invasion you classify. The T stage is dependent on the extent of invasion of the tumor. The N stage is based on the number of nodes involved. Earlier it was based on the location of the nodes, now it has shifted to the number of nodes. M is for the metastasis, and then you also have a histological grade. Briefly, I would like to touch upon the 7th and 8th systems, where there's a what is the difference between the 7th classification and the 8th classification. So the N3 group has been split into A and B. This helps in prognosticating it better, and there's further subdivision of stage 3, A, B and C. Again, this helps in correctly prognosticating patients. Okay, a very good addition is the YP stage. So after neoadjuvant, earlier you were not restaging again, you were going back to clinical staging, but now you have a dedicated stage post neoadjuvant therapy. And also there's a change in the classification of G junction tumors. It's defined as gastric if the epicenter of the tumor is 2 centimeters below the G junction. A small example on how that helps: say a patient who has shown a very good response now becomes stage 2A, and then you can avoid unnecessary overtreatment. TNM again is something which is being revised every 6 to 8 years. It is still not extensive, but we hope that as we go on into the future, a lot of other factors are taken in. A brief overview of the staging pattern. How does it help? So this is very complicated. I'll give you a simpler thing. The early stage 0, stage 0 is for endoscopic resection. You can go for EMR or ESD. Stage 1, you would go for surgery upfront. Stage 2 is where you considered perioperative chemotherapy. Stage 3 is again neoadjuvant surgery if possible, then adjuvant, RT if margins are positive, and stage 4 is metastatic disease where you avoid it. You can look at the prognosis, the 5-year survival, and this is why staging becomes very important. As you go down the stage, the survival drops rapidly. The Japanese, they were extensive with their lymph nodal dissections, and that is what has defined today's D1, D2, D3. They are very comprehensive with the tumor location, and they also include lymphovascular invasion.